All right, good afternoon. Hope you all enjoyed lunch. What a beautiful day. We were actually debating whether we could take this outside, but we were told it would sort of deconstruct the whole AV, and it would seem like a bad idea, so we're not. So I am joined here today by an illustrious panel. Do you all want to just take a minute and introduce yourself and your organization? Holly, go ahead.
Go ahead, Lauren.
Hi, everyone. I am Lauren Riplinger. I am the Chief Public Policy and Impact Officer for the American Health Information Management Association.
Hi there, I'm Duncan Weatherston. I am one of the founders and the CEO of Smile Digital Health.
My name is Holly Miller. I'm an internist and the Chief Medical Officer of MedAllies.
Well, thank you for joining me. I know this topic is really important and that you all feel very passionately about it. I'm going to spend about 2 minutes just setting context, much of which has been covered by Dee Davis. And I'll lead off with maybe one question, but I really think just in the prep conversations we have, you all have a lot to share with each other. So I see this more as a roundtable discussion than really anything formulaic. So what is data usability taking root? We knew that by developing an implementation guide, that was one resource that would help serve our community in helping to take steps to improve data usability. But we know that just because you develop a resource doesn't mean it will actually be put into practice. And so we felt very passionately, as did our members, our community, that we needed to really make sure that this activity, that this guidance was actually put into practice. And we contemplated, well, how do we do that? So you all saw the 6 category areas that the guidance in version 1 addresses. Taking root is really unique in that it's the activities that are necessary to put the guidance into actual practice and use. So we partnered with AHIMA to actually bring that effort forward and to develop a community of practice to continue working on how do you interpret, apply the guide into everybody's respective organizations. We also recognize that there might be a need for technical assistance to help interpret and apply the guide. And that it would take shared understanding, shared learning. So we actually host monthly roundtables to sort of unpack how this, could work in a coordinated, collaborative fashion, and then have a way to test the Taking Root Data Usability Implementation Guide, and Dee Davis has been working on a testing tool there. So we had our very first Data Usability Summit in September of 2023. It was extremely well attended, and the conversation was just really robust. I mean, these are not presentations. I mean, the summit was all about really trying to share about how folks are understanding it, what aspects of the guide that they could implement, and all of that will feed back into the data usability workgroup. So they develop the guide, and Taking Root Movement implements it. So we have a number of supporters. These are folks that believe in the importance of this. They may or may not be in a position to actually implement the guidance, or they're evaluating the extent to which they'll actually make a commitment to put this guidance into practice. So we have 10 organizations so far who have publicly stated, we're doing this. And we're going to make a concerted commitment to put this into practice. And then, of course, folks who have been incredible in supporting our work, again, in partnership with AHIMA. So this is an example of the type of technical assistance we're providing. Some of them are really toolkits, contracting, more business-oriented communications, potentially offering training, and then testing and conformance tools. One of the elements is actually a scorecard. So this has been drafted. We are actually looking for feedback on this because we want to have a resource that folks can use to see how far and what progress they're making towards implementing the guidance. So you can see there's a link to the Google documents, and welcome any feedback on that. So with that, I will open it up by saying, what does data usability mean to you? Why is it important? And just sort of interpret what this means.
So if it's okay with my colleagues here, this is probably the panel that gets along the best of any panel I've ever been in. We just have had so much fun prepping and discussing what we think. So, but as an internist, I think the last mile was referenced earlier today. It's really taking data that's been received and applying it immediately to the care of the patient that I'm seeing. And that's critically important as we move forward in this world, to really be able to have trusted, reliable data that's usable. And in all of those 6 categories, has been processed and is made available.
No, Duncan, go ahead.
Right. So, as a guy who's a bit of a geek and has a history as data implementation architect, usability to me has a number of connotations. On one level, it is entirely about the premise that the data usability taking movement has, which is about making really effective use of information in clinical settings, and allowing clinicians to deliver better care to patients and allowing patients to understand the character of their care more effectively. But on another level, it's about the relationship between information at source, the information as it's stored, information in transit, and the ability to use that information subsequently for automation and for other value propositions in the grander scheme as you move forward through time. And then lastly, when you think about usable information, it has to be pertinent to the topics that you're trying to go after, right? And so when you think about usability, applicability can't be missed. And applicability, as the white paper points out, includes things like provenance, the ability to figure out who made this assertion. It means semantics, the ability to assure that the types of information we're exchanging are understandable in all of the users and in all of the use cases that you're accessing it. And so I think from my perspective, it's a multi-tiered kind of problem. And lastly, I'm going to hand it over to policy. I think at the top level, and the most important piece for a community like ours, is the ability for everybody to understand at a meta level what usability means. So I'm going to pass it for policy.
Yeah, thank you. Thank you for the question, Mariann. So just to kind of level set in terms of who AHIMA represents, we're a professional association that represents health information professionals that work with data for 1 billion patients a year, right? So they are really in the day-to-day mix of how do we manage this information. And so from a practical perspective, when we think about our members, for over 90 years, they have been committed to ensuring the accuracy, the integrity, the quality of health information in individuals' medical record. And so when we think about data usability, while it's different from data quality, they are inextricably linked from our perspective. And so that's kind of the next level in the stack, so to speak. But even broader than that, for us, this is about doing the right thing. And so when we think about and why we committed to this movement is that, our vision as an association is to, transform healthcare through trusted information. And in order to do that, if the data is not usable, if it's not complete at the end of the day, how can we trust that information to make clinical decisions, to make payment decisions, to make operations decisions? And so that's why we believe this work is so critically important.
So what needs to be done? I mean, we've talked about the problem, and what needs to be done to really make a dent in this?
You can start this time.
Yeah, I'm happy to take it. From our perspective, it's really a top-down and a bottom-up approach. So when I think about the top-down, one of the things that we heard in the Data Usability Summit in DC in September was really, how do I make the case to our senior leadership within my organization? And that's really critically important, right? How do we make the argument that, embarking on this journey will reduce readmissions, improve outcomes, reduce costs, all the things that our senior leadership thinks about on a day-to-day basis. So I think that's a really critically important piece of it. When I think about the bottom-up approach, it's how do we integrate, and I know Dee Dee and Dr. Greg talk about this all the time, how do we integrate this work into pre-existing work, right? And being really thoughtful in that approach. So for example, one of the things I think about is, we know that many organizations have a data governance team within their organization thinking about these issues. How do we integrate the conversation around data usability into that work so that you already have this really core group of individuals that feel very strongly that data management, data governance is really important, and this just becomes, an aspect of that work in those committed group of individuals.
I know you've got a strong opinion.
Yeah, well, I definitely want to respond to what you just said because I think that's so important, but I want to start with MedAllies and why we think this is so important and what we've done about it, which is we've been doing very active development work. So MedAllies is a network company. We have a direct network, a HISP. We have a care quality exchange network, and we are a QHIN candidate. And we have built the functionality such that information traveling across our network has the version 1 data usability implementation guide. So all of those 6 areas we've developed such that the recipients of messages traveling across our networks will be deduplicated, will have core data, coding, et cetera, and we're at a point where we're so excited to test this and get others involved, because we have to check and make sure, did we get all this right? As it goes across, do we end up deduplicating anything that shouldn't have been? Do we end up having core data that should have been tweaked another way? So we're very excited to test this with others. Let me know if you are ready. And then I wanted to address what Lauren said, and then over to you, Duncan, because we were talking about this offline before, and Dee Dee and Bill have done phenomenal leadership in this group. But what Lauren was talking about was another aspect, which is there is still work to be done having clinicians perform better documentation at the point of care. Because people will document a UTI, and that sits on the record for years without anyone taking it off of the problem list. Physicians will omit a start and end date of an antibiotic so that that stays on the medication list inappropriately and would get transmitted over a network to another provider, even though the patient hasn't taken that in 3 years. So we do need what Lauren was referring to, which is groups that are going to work with providers to make sure the documentation is cleaned up. Because no matter what we do for data usability and the phenomenal work that's gone on and continues to go on, we will at some point need to address provider behavior.
Yeah.
Duncan.
So I think, at the risk of being a little confrontational, I guess everybody here is accountability. I've been working as an architect in healthcare for 25 years or more, and I have seen over the years poor quality data. I've seen lackadaisical implementation. I've seen environments where people view information infrastructure as secondary to the purposes of delivering care. It really is time for us to start changing the way we think about information in the process. And like you said, it's clinicians, but it's not just clinicians. It's
EHRs that
EHRs.
Make it difficult.
It's people who have accountability for the information infrastructure in health providing organizations, in consumer organizations. It is a real assessment of what we think healthcare can be in the future. And at the risk of being a bit out there, I think where we have to get to is healthcare being delivered through devices that are meaningful to us, right? Through automation, through a direct personal relationship like we've had in the rest of the economy. You have a direct relationship with your banking. You have a direct relationship with your food purchases. You have a direct relationship with your music. In healthcare, you have, as a patient, a one-step removed relationship. And as a provider, you're in a position where you have, as a consequence, disinterested patients frequently, or at least challenging circumstances, and an infrastructure that isn't supporting it. We need to be transformative, not because it's a fun thing to do, but because in order for us to meet the cost, the advancement, the growth, the social equity, we have to rethink our whole relationship with information. And so with that in mind, like I said, being a bit confrontational, it's up to you guys, right? Everybody in this room is part of the team that's accountable for this in one way or another. When you go back to your day jobs and you leave this lovely location, remember, you're part of the data usability solution.
No, I wholeheartedly agree. I mean, data usability is not the sexiest topic when you think about it, right?
Oh, yes,
but
it is.
I mean, to us it is, obviously, right? But it's, it has to be done. And I totally agree with you, Duncan, that it's about rethinking our relationship with health information.
And Lauren, earlier you were talking about, and this made my ears perk up, because we've been talking a lot, the three of us, but you were talking about decreasing burden for clinicians and clearly for patients, and a lot of that is documentation burden.
Yes.
And so I think one of the ways that all can be enhanced and improved, and this is something MedAllies has focused on for years, is implementations. How do we really train correctly the usage, both at the documentation level, but also at the receiving level, so that the data that's coming in, if it's trusted, if it's usable, after all this work, can easily be reconciled. So we're basically essentially making the patient's record for the patient, for providers, a universal record that's where elimination of data that's unnecessary or dated or was never applied to the patient, the example that was given earlier of a wrong vaccine that was entered, that we've cleaned up the record and it's accessible and usable, and making sure as we implement that people understand the importance and understand the best and easiest ways to do things.
Yeah, I mean, a lot of it is, yeah, I see two pieces of it. One is kind of the call to action from an organizational perspective, right? Is how do we bring people along in the conversation so that they buy in to those ultimate goals, right? Having that North Star. The other piece is, and putting on my policy hat, right, is what are the policy levers we need to think about at a federal, state level in order to really move people and encourage them. And, I know we're just talking about QHINs coming online at the end of this year, but there could be opportunities at some point further down the road of how can we leverage TEFCA in ways that really encourage people to go on this journey of data usability and taking action.
Mm-hmm.
Absolutely.
So in terms of, you've touched on a number of times the impact, but I wonder if you could just sort of summarize, maybe weave in some real world scenarios, the impact.
Sure, maybe I can.
We talked about some specific examples, but I mean,
So maybe I can start. I mean, obviously, as a person who sells software to healthcare organizations, we get a lot of instances that we can sort of refer to. I'm not going to mention anybody by name, but an example of how it's beneficial to everybody. One of our clients that deals with many, many patients and in many clinics had a lower stars rating, had challenges in managing the information as it went through their environment, and came to a conclusion they were going to switch to a structured data strategy from day one. And so at the patient engagement interface, they collected structured and quality information. They bound it into their workflows. They then made it available back out to their consumer engagement pathways. And the net effect was, I think they went up like either 1.5 stars or 2 stars, making a vast sea of cash for themselves. They had a very, very satisfied patient population that grew. And then the clinical services they delivered were better. So on the back of all of their efforts, and they were pretty intensive efforts, the whole organization prospered. And they went through, some pains, because whenever you do new technologies, things fail and you have to live with the weight of it. But the net effect was that the realization of usability was evident in all aspects of the care journey and all of the behaviors of the participants, patient, provider, and others.
Ron, did you?
No, go ahead.
So as a clinician, the benefits are just so blatantly clear. If I'm seeing a patient who's already had a battery of tests a week ago, I'm not going to duplicate those tests. So as a patient coming in, I'm not going to get stuck 5 times again because my doctor had the tests and knows that they're reliable and trustworthy. In terms of needing the information to care for the patient and having it in front of me, then validating or verifying with the patient, is this all correct, enables efficient care. Now, in the days when we were fee-for-service, doctors wanted to see patients 3, 4, 5 times because they got paid more. But now that we're moving towards a value-based care model, as a specialist, the specialist wants the information to have 1 visit or 2 visits maximum with the patient to make sure that they are covering everything and providing the care that's been requested. So the efficiency, the value is apparent, and we will achieve this through appropriate data usability. Lauren?
No, I mean, both of you well said. You know, you all are much more kind of on the ground and can provide those real world examples than I can.
But you get it, Lauren.
Yes.
You're all over the policies to make sure it works.
Exactly.
I'm going to talk about one more then maybe. We work internationally, so we have work we do in Ontario as well, in Canada. And my background as such, I was involved in many of the activities there. What we've seen over the years, and this is kind of why I was being a bit sort of upfront about it, we've seen the importance of information and the use of information increase in value and be augmentative to the delivery of care as we've been able to add assets to the clinical experience. And so in Ontario in the early 2000s, we created a big lab collection. Prior to that, or in parallel with that, we went through a process most other people did where we removed, we went to digital imaging, so we saved a bunch of money in terms of fiche and storage and everything else. We went through a process where we gathered all of the hospital data and made it all available back out to the hospitals across the province, the state, however you want to think about it. We then grabbed all of the drugs we could, and in Ontario, we pay for drugs for people who are over 65 and under 27, so we got a subset of the drugs. We're in the process of gathering all of them. But we built it all together, and we put it together in an interface that went to clinicians. And because I was involved in it, every time I get a chance, I ask them about, like, hey, is this working for you? And what I've seen is, when we first implemented it, 7 years ago, the full package kind of rolled out 7 years ago, people were frustrated because it wasn't Google, right? They were expecting this new thing to roll out and they would be able to have a Google search for data and move on. Over time, the performance improved, the content improved, and now when I ask people about the package, instead of having a story from me about, well, we use it this way, we do that, they assume I'm going to ask them for information about somebody somewhere. They don't even think about, should this infrastructure exist or does it add value? The meaningfulness of having real clinical information at the point of presence where you're interacting with a patient is now a critical component of the care delivery system. And I think it's that experience, watching, and for my family too. When my daughter is in the hospital, I've had cases where the systems we built improve the quality of care for my family. It's a very, very rewarding cycle. So when you think about the effectiveness of the usability when you go back to your environment, you can take your personal experiences with your family and your neighbors and your colleagues, because all of them are patients, right? And I think then you can start to see the value of the usability you've brought because people are using it, right? And I think, if you wanted to say, what does that look like? What does usability really mean? It means people are using it, right? That's the thing. They're getting value from the data that you've presented them. And there is no more rewarding aspect to what we're doing than helping our family and friends and neighbors.
Well, and for patients too. I mean, you kind of alluded to that, but clearly as we move forward, we published a paper over 15 years ago from the Cleveland Clinic data, which was essentially the individuals that were using the portal, the patient portal, was not gender related, it was not age related, it was not race related, nothing like that. It was the number of diagnoses that the patient had. So those that were most medicalized were most likely to use the portal, which makes sense because the portal provided services like appointment scheduling and prescription refills. And so as we get into a world where patients now will want to use their data, making it accessible to them, but again, the importance of the data usability V1, V2, V3 guides coming up, because to have the right information for the patient makes it so much more comprehensible and usable and makes them the best advocate for their own care and a huge and permanent member of the care team.
Yeah.
But we've kind of denied them that in the past.
Yeah. Actually, that reminds me of what you just said, the portal, because this is silly, but it is indicative. So like you said, today our portals are used primarily by people with complex care conditions that they need a lot of attention.
And I would argue that they always will be.
Yeah, except when we first did it, the thing they were most interested in, what's up for lunch in the cafeteria? That was the most usable data on the portal was, what's for lunch in the cafeteria today? So we've gone a long way, right? That usability process has transformed. It's no longer, what can I eat, but how can I get care? So I think there's just one of those transitions. We're going to see more as we go along. It'll seem like what today we think of as usable is in
Damn,
fact.
we didn't offer what was for lunch at the cafeteria in our portal. I should have thought of that when I implemented it.
What's interesting is you both talk because, you talk about the different stakeholders, and to me that raises the question of, who needs to be involved in this work, right? Yeah. And we saw this on the slides that Dee Dee provided and Dr. Greg this morning of all the different people who are involved in the work group here. And, it was providers, it was developers, it was IT, it was HIM, all these different people. And to me that says this is not just one issue that one department is going to own in their organization, right? So I think about my folks, not all of them work on the IT side, right? They may work in health information management or the medical records, right? But they understand where the data needs to flow, and they understand the operational needs, regardless of if it's clinical, if it's payment, if it's operations, et cetera, right? And they understand the controls around it. But they can go and they can ask these questions of their IT team, of their compliance, all these different stakeholders. And so when we think about that, I think it's critically important that we recognize that this is about all of us coming together to really, make progress on this work.
And I think that really came out, and correct me if I'm wrong, Mariann, but I really think that came out in our summit, the Taking Root Summit, because it was very clear that we wanted all of the other groups, the patient advocacy group, to dramatically participate in the data usability work that's going on, because we want it to be, as you just referenced, include all of the voices.
Yeah.
Absolutely. We recognize when Sequoia got such resounding feedback and support to work on this issue, and the board even acknowledged, they said, this is not going to happen quickly. This is going to take maybe a decade, maybe longer, I don't know. So in your view, how do we know we're making progress, both in short-term and long-term, and how do we know if we've succeeded?
Do you want to start?
Go ahead.
So like I alluded to earlier, for me, success is a long-term thing. Success looks like all of us having a personal relationship with our healthcare through a device or through some other channel that allows us the kind of control that we have over our financial systems today. When you wake up in the morning and you can see what your next best action is, when you know what your health indicators are, when you know with concrete certainty how you're going to navigate the next day, week, month, year, and remain healthy and have the support from your community, from your information, from your peers, that's when we're successful, right? And that's a long journey, but we know it's possible because just have to look at every other industry. Every other industry's done this. So I know we can get there, but we've got a lot of work to do.
Lauren, do you want me to take it, or?
Sure, no, I'm happy to. So I think about success kind of from 3 different time horizons, right? So if I think about 6 months from now, what does success look like? In my mind, it's the scorecard that Mariann referenced. People are taking that scorecard and starting to ask questions in their organization. Do we do this? Can we do this? How do we do it, right? And how do we work together? So that's kind of the first time horizon. The second one is a year from now. And in my mind, success looks like people are asking Dee Dee, where's version 3 of the implementation guide? I see her applauding. She may be not applauding by the time she gets to V3. But it's also, I see a year from now, people sharing success stories and the early adopters of here's what we learned, here were our challenges, here's how we addressed it. So then we really begin to accelerate and build momentum behind this movement, right? Because as the question that came up this morning is, this could take us 10 years. It's incremental change that we have here, but we wanna get that critical mass at some point, right? 5 years, and I was sharing this with Holly and Duncan earlier, is that to me, success looks like 5 years from now, that data usability is a standing agenda item for the data governance team within an organization.
Love that.
So that it's just core to what they do and what they think about when they convene.
Love that. So part of my heart will always be an implementer. And I love implementations. I love working with staff and physicians to implement. And with that in mind, we always had a crawl, walk, run analogy. And the crawl stage was making sure there's the cheat sheet with the images and where you click. And then the walk stage was, hey, this is helpful. I can like this. And the run stage, which I am looking forward to like nobody's business, is I can't practice medicine without interoperability, without usable data and interoperability. It's not possible. So, which, if you talk to physicians now, I think back in 1999 when we implemented at the Cleveland Clinic, the kind of, I mean, there were some of the staff that I was in charge of would run out of offices screaming because no, would run out of offices, I'm sorry, crying because the head of the office was screaming at them. The physician chair was screaming at them because I'm not going to do. Now, not a single one of those doctors would dream of practicing medicine without an electronic health record. And that's what I want for interoperability, and that's how usable the data needs to be for doctors and clinicians and patients to say, this isn't happening without interoperability. I'm not going to do it.
Yeah,
I mean, it's so foundational. I mean, so many of the things we heard about over the last day and a half have, I mean, to achieve any of these goals and really engage and empower consumers, I mean, it's all about the data. So we do have about a little more than 13 minutes left. I wonder if we open it up for some questions. I know we have a lot more we can talk about. I see, there we go. Thanks, Ollie.
Hi, David Mendelson. Excuse me. How do you think the emergence of large language models is going to influence the work you have to put into data usability?
I guess I'll tackle that one.
That's got your name on it.
Yeah. So I think there's a progression there, right? I mean, like any set of tooling, there's going to be a level of comfort and trust in the tooling that's got to expand. Personally, I think in the early stages, LLMs provide value in a number of places. I'm going to circularly come back to data usability in a second. LLMs provide us with a mechanism to have conversational interactions with patients, providers, and others that are informed by the context of the conversation in a way that chatbots historically have not been able to do. So we can gather information, we can ask questions about the information, we can have the LLMs interact with people, we can have the LLMs read things and then provide back evaluations of it. And in the short run, what that enables us to do is have processes that imply or deliver value to spaces where we can have meaningful validation of the output. So an example of that might be the ability to ingest a set of information about a patient and provide back some assessment of it, some recommendations, some summarization of the pieces. The ability, for example, to pick quality information. A really cool use case, one I like, is the ability to pick a bunch of high quality information and then return back some narrative summary data about the thing so that a clinician can use it, right? You can imagine you've got a pile of documents and I want, as a clinician, to be able to understand what's relevant to me from those documents for a particular case. I have patient data, so I can tell the LLM in the context of this patient, in these circumstances, against that record set for that patient, for this outcome, can you give me a pertinent summary? And an LLM can do a really great job of that. I think there's a secondary use case where we want to try and create rules, where we want to be able to say, assess the things that we've written as rules and provide me with an automation pathway that I can review and create automation off of. There's a huge opportunity here for us to take written language and, like we do with a thing called Copilot, be able to create code or similar close to code stuff which we can validate. And I think LLMs then also go on beyond that to start providing some of the rationalization and the justification. You can say, my LLM came to this conclusion based on this set of rules and this particular aspect of the set of rules, and somebody else can validate it. Or even more cleverly in the future as you go forward, you can have a separate LLM whose job is to doubt it and tell it it's wrong, and then you can get a higher level of quality believing the outcomes. So there's a bunch of pathways, and this is just iteration one, right? The LLMs we have today are going to be superseded dramatically. You know, think about the way everything else in this space is gone. We've had, chips that were running in megahertz, and now we're in, gigahertz, and depending where you get to, higher than that. Sorry, that was really technical. I'm sorry for being a geek. We have things that operate, at 100 and then 1,000 and then 1,000,000 and then 10 million. Think what that means for AI. We're right in the early stages. These algorithms are using technology that's not designed to optimize them. They're written by people who have great ideas. They do some really interesting things mathematically, which we can improve on. The opportunity here is that we're going to learn repeatedly from this, and ultimately, the response is going to be trustworthy, and then when you get back to it, we can trust it to create quality data, we can trust it to tell us about what we know and produce the things that we believe in. So I think the LLM pathway is in its early stages. There's a bunch of great use we can get now, and I think we can iterate on that as we go forward with outcomes that are way more meaningful and in timelines that are surprisingly short, right? Think about how things have changed just in the time since the base implementers that became LLMs were modeled. That was a couple of years. If I think about the couple of year iteration, we're headed for a pretty remarkable future.
Great. I think we have a question over there.
Yeah, I just wanted to say it's really exciting to see the energy and enthusiasm from all of you. And I think what you're bringing to this is how we're going to get it moving. And I think one of the most important things I think I heard you say was bringing data to the center, so that it's, I see a lot of organizations that I've worked at over the years where data is kind of a byproduct rather than being central. And I wonder what your thoughts are on, in this age where there's a lot, staffing is tight, revenues are down, and everything, how we make the case, or what you think the first steps are to all of our organizations to really get it to the priority level. We think it'll deliver a lot in the long run, but how do we make those first steps?
Who wants to take that?
So, I think it goes back to kind of the bottom up and the top down, the down approach, right? Is, to your point, Bill, like making the argument to the C-suite, how does it reduce cost? How does it reduce readmissions? How does it, reduce that cognitive burden, right, that our providers and others are suffering on a day-to-day basis? I think that's kind of a key piece to those conversations. I also think, how do you leverage regulatory and compliance levers? I also think that's a key issue that leadership pays attention to at the end of the day, right? The other thing I'd say is, from my perspective, I'm gonna take my policy hat on, put on my association hat, and that is, we can't discount the opportunity that associations have to really drive adoption and a call to action in their community, right? Because we know that whether you're a professional association or a trade association, your members come to you for best practices, for guidance. What is everybody else doing? How do I keep up with everyone else? And so I so appreciate the fact that EHRA and Civitas and others have come to the table on this movement, because they're saying, we're putting a stake in the ground, we believe this is important, and we're going to push this and share this with our members to really drive adoption and make change.
That was Bill, right? The lights are in my eyes. Bill, it's interesting, because I would say, let's not put the data in the center. Let's put the patient in the center. And to that end, I referenced, we are so excited to test what we've built. But what would be fantastic, because we could do this in Sequoia, as I referenced, because we have a patient advocacy group, let's look at some actual data or pretend data and say, does this seem right? Is this correct? So have it validated with the patient as we do our testing. So I think that's such an exciting opportunity to me. And then when we get, that checklist, the testing done, and it's correct, adoption will flow, because people will want this.
Well, that's the other piece too, is having metrics for success, right? Mm-hmm. And so if we can come together as a community, like the scorecard, and say, look, this is what success looks like in our mind, at least initially, and then you can show the results and the effect of when we follow these things, what happens, what's that kind of trickle down effect. I think that's a very powerful story to tell leadership.
I've been demoing different things for years in the interoperability showcase, but imagine having a demo not with real data, but having a demo where we show in a large forum how this works. Everyone will want it. It's fantastic.
Exactly. I think you might have a couple volunteers in here who might actually be willing to participate in that pilot. I think Michael.
Thank you. And I was reminded listening to this of the conversation yesterday with the Consumer Voices group, and the often heard complaint that your average patient caregiver has trouble understanding the data that they have access to. And so I'm just wondering what your thoughts are about how this effort ultimately can be bridged to solve that issue.
I can. So there are absolutely, positively fabulous websites that go through, for example, a laboratory test explaining exactly what each element means and what the abnormals, what the normals, et cetera. When we implemented the portal at the Cleveland Clinic, we had links on every message that was sent out to these things. So I dream actually of a day when there's and this is maybe something Sequoia could take on in the patient advocacy group, is my own experience is when patients advocate for themselves, their outcomes are so much better. And it's critically important that happen. And so that we could pull together, there's so much now that's out there about physician outcomes, surgeons' results, and how many cases they do, et cetera, et cetera. These would help individuals make decisions about their health care. So if we could pull together a site off of Sequoia for patients that had these materials available, how fantastic would that be? Where I could go there if I got a lab result I didn't understand and just, there's a link to something that can explain it to me. Obviously, communication has to improve with the patient and physician. But I do think, and it's funny because I think that patients should get information the minute it's available, which leads to that anxiety because the physician hasn't explained. But nonetheless, and I'll speak of a personal example. I remember one time I had a patient and she had osteopenia, and several years later we did another bone scan and she still had osteopenia. And I said, do you still have osteopenia? Nothing changed at this moment, continue your vitamin D and calcium, et cetera. And she said, yes, but if you look at the results, the scan is actually a little bit worse. And so we agreed to start treatment. She was advocating for herself and I loved it because we did start treatment and then the next bone scan was improvement.
So I think one of the things that we get from data quality and from structure, I've got two answers. So the first answer is a more practical and immediate kind of thing. One of the things you get from data quality is semantic consistency. And if you've got semantic consistency, then I can use relatively established translation capabilities to say this clinical thing looks like this patient thing, and then I could even have gradations of this patient thing for somebody who's got relatively experienced interaction with their information, somebody who's new. You can imagine that the structure of information is consumable as long as it's consistent. The moment I have ambiguity in my information, then I'm going to have ambiguity in my answers, and I'm going to be stuck in another position. The second answer, which I think is probably in alignment with, I'm going to touch on both questions at the same time. I think there is an opportunity in the space we're headed to with LLMs and other pieces to be able to demonstrate real value to people, specifically around these types of things, where I'm going to find a way to take information and expose it in more meaningful fashions in a context that's relevant to the questioner, right? So you can imagine if you get a lab, if you've got a particular consideration that says, here's some values that you've got back, you could say, what does it mean? It may say, it means you've got diabetes. You could say, no, what does it really mean? It may say, well, it means that you're probably going to have to watch what you eat. And you say, no, what does it really, really mean? And it says, well, stop eating bread and eat a bit more vegetables and maybe go for a run, right? Like, you can get through that process in conversation with an LLM, which you can't get to with a translation, right? And when you get to your question about what does it mean about drawing data to the center, gotta get quick.
Yes,
the last
you do.
30 seconds.
No, 10 seconds.
It really means that we have to have the ability to use the information technologies that we have appropriately at the time that the information is gathered to be able to give people back the information they need as they ask for it.
Well, as you can tell, there is no shortage of passion and interest in this. And we've spent so much time as an industry promoting the exchange of information. If we can shift that paradigm and focus on what we're doing with it, I think will make real import. But thank you all for joining me today, and I think we'll have more conversation to come.